Hello, everyone. Thank you for joining. We are continuing on with the glaucoma lectures today, and there's going to be a quick session today on iatrogenic glaucoma. So, high pressure states that we as surgeons can induce in an otherwise healthy eye, or at least an eye that was previously uncomplicated with glaucoma. Um, so the main things that we're going to touch on today is aqueous misdirection, which can happen after quite a lot of different surgeries. We'll talk about what it is, what the sort of mechanism is behind the high pressure, and ways in which you can treat it. And then we're then going to touch on the kind of glaucoma that we can cause either by doing just simple cataract surgery or the kind of things that you can sometimes see after vitreoretinal surgery. I have spoken about complications of glaucoma surgery previously in an earlier tutorial, so you can go and see the kind of complications that can happen after trabs and tubes, and what to think about those sort of patients. So this was more a kind of a conversation on glaucoma that's caused after surgeries that are otherwise unrelated to glaucoma specifically, and in patients who otherwise don't have glaucoma. So starting off with aqueous misdirection, um, so essentially what the idea is here is that the ciliary body has essentially shifted, and the aqueous is, rather than coming forward in front of the lens through the pupil and into the anterior chamber, it's actually being pushed backwards. And what you can see in this diagram is that essentially what that means is that aqueous is being pushed backwards. It kind of travels there behind the vitreous, and the vitreous is pushed forwards, and then the vitreous will push on the lens. It can push on an IOL that can then push against that pupil, flattening your anterior chamber, and increasing your pressure by essentially causing a secondary closed angle. Um, Now, there are different risk factors. Now, this can happen in pretty much anybody, but there are certain sort of features of an eye that make it slightly more prone to developing aqueous misdirection after surgery. And that would be something like a hypermetropic eye, maybe non-ophthalmos, patients who've previously had angle closure. And sometimes the surgery itself has an increased risk. So specifically trabeculotomies and tubes, but again, that's discussed in a different session. But also actually cataract surgery can cause this as well, and a lot of that has to do with the flow of the fluid throughout the surgery. And very, very rarely, patients who are on miotic treatment for whatever reason can also cause aqueous misdirection. Now, the thing is that aqueous misdirection, most of the time, you're going to see these patients post-operatively. They will come in for a post-operative review. They'll have high pressures. They'll either come in as an emergency or you'll be seeing them routinely as in clinic. And you might find these patients with very, very high IOPs. The lens has moved forward, so they might have a myopic shift. They may have a shallow, a very flat anterior chamber. But actually, it can happen intraoperatively. So even while you're operating, the eye can go into aqueous misdirection. And this is where you're going to get the features similar to something like a suprachoroidal, where you have a sudden loss of your anterior chamber, a very sort of high pressurized eye. The contents of the anterior chamber might be wanting to come out. So you might have a lot of iris prolapse, for example. And it has happened to me. And it's quite important that intraoperatively, your management is very much to sort of essentially try and stop your surgery, make the eye safe, suture any wounds, and let the eye settle down with the management of aqueous misdirection, which we'll talk about in a moment. It's really important not to try and just power through. There are obviously ways to try and manage it surgically, which we will discuss, but generally, if you're in the middle of a cataract operation and you don't have those tools to hand, it's sometimes best to just let the eye settle down and be safe. It tends to happen. I mean, it's happened with me, and it's also I've only ever heard it happen one other time with a colleague of mine, and in both situations, it's happening just as you're finished taking out that nucleus, and it's essentially that debulking that it suddenly causes a shift essentially in the fluid dynamics, and I'm not entirely sure why, but that's when I've seen it happen in the past. And post-operatively, like I said, these are patients who are going to come in with quite high pressures, really quite malignantly high pressures. We're talking very similar to your sort of acute angle closure, 50s to 80s, really, really quite high pressure. Because that lens has shifted forward, they may have a myopic shift, but essentially they'll just have some blurred vision, and a shallow or a very flat anterior chamber, like I said. And when it comes to the management, you've obviously got the acute stuff, which again is going to just talk about things like, trying to create a patent PI, giving that aqueous another channel to flow through if you can, dilating the eyes. So things like atropine, phenylephrine, can help shift that ciliary body back into the right position. And obviously, you're going to just treat a raised IOP in the way that you treat a raised IOP. So you're going to want to give some topical treatment, something like an aproclonidine, a prostaglandin analog, and a beta blocker as well. But then you also going to want to try and give some acetazolamide as long as it's not contraindicated in the patient. And that's just about managing your pressure, but really trying to managing the aqueous misdirection, specifically mydriatics, can sometimes help shift the shape of that ciliary body back into a position which pushes it anteriorly. Then in terms of your surgical measures, you can do YAG laser, and the theory behind what's going on here is if you go back to what's essentially happening in aqueous misdirection, where the vitreous is coming forward, you want to try and disrupt that anterior vitreous face to try and give the aqueous space essentially to move forward. And you can do that either with just yagging the anterior hyaloid. So you can do that just basically through the lens if the patient is pseudophakic, or if they're phakic and they have a PI, you can sometimes just yag through the PI into the vitreous. Cyclodiode can help settle down an acute attack as well. But there are surgical measures as well. So one of the things that you may have heard of is a zonular hyalodectomy, and that's basically coming in from the front through the iris, pushing through the zonules, and then essentially performing an anterior vitrectomy. And the idea behind this is you're trying to essentially create basically a uni-chamber eye. So you're trying to create a channel between the front and the back, so that you no longer have two chambers. And that's what you can try and achieve with a zonular hyalodectomy. Or you can consider a vitrectomy as well. So literally just by getting rid of your vitreous, you're essentially going to stop the problem from ever happening again. And actually, sometimes in patients who have chronic aqueous misdirection, who come in and out of aqueous misdirection, sometimes the definitive management is actually just to send them over to our vitreoretinal colleagues and just have them have a PPV, to just completely nip this in the bud, essentially. So that's aqueous misdirection is something you're not going to necessarily come across it a lot, but it can be quite devastating to the eye because it can mimic a closed angle attack, in which case the pressure can go up very, very quickly. The damage to the nerve can happen very quickly. So being able to sort of recognize it, understand the risk factors, and then how to manage it can be really helpful for you in your clinical practice. Um, and just a couple more kind of comments on the different types of surgery as well. So with cataract surgery, there's lots of different things that can cause a high pressure state in the postoperative period. And whenever you're kind of assessing a patient after cataract surgery, these are the things that you want to sort of try and think about, when it comes to figuring out why the patient has come in with a high pressure. So sometimes you might have some retained viscoelastic. Now, viscoelastic in the eye, so especially when you're doing your lens insertion, for example, you've put in a cohesive viscoelastic to make everything nice and big, give yourself some space to put in a lens. But sometimes that viscoelastic can sort of be trapped behind the lens, and that can dislodge in the postoperative period and then land itself within the angle, blocking the trabecular meshwork. And retained viscoelastic can really cause quite high pressures as well. You're more likely to come across it with a cohesive than a dispersive. But cohesives are also easier to remove from the anterior chamber, which is why the cohesives are sometimes used. But a dispersive is sometimes less likely to cause a high pressure, but both can cause high pressures. And essentially, the way you're going to try and manage that is managing a pressure and waiting for that viscoelastic to basically dissolve, and it will over time. But if you feel like you've got quite a lot, then actually the patient might just benefit from an AC washout. I remember having a patient coming in after a phaco plus hydrus, and essentially when you actually assess them, their anterior chamber was completely full with viscoelastic, and that's possibly because, if you're doing a phaco hydrus, if you're doing a phaco eye stent, and you've seen that sort of thing happen, you're usually in the flow of cataract surgery where as soon as the lens goes in, you empty the anterior chamber of any visco. But with an eye stent or a hydrus, the visco remains in the eye, you turn them around, the flow can be interrupted. And if you're kind of only just starting doing that, um, then that's possibly what I thought may have been the reason. It was a patient who had come from a different center into eye casualty, and just basically had an entire anterior chamber filled with visco. So the visco had essentially just been left in and forgotten about, and their pressures were very, very high. So a visco like that, if you have that much, you're not going to wait for that to dissolve. The patient essentially just needs an AC washout. But if you only have a tiny, tiny bit, then sometimes you can just manage the pressure and wait for that viscoelastic to dissolve. Inflammation after surgery can cause high pressures, and you just manage the inflammation basically and manage the pressure. And then there's sort of stuff related to your IOL. So if your IOL is displaced for whatever reason, if there's trauma after cataract surgery and the IOL is displaced and starts to block the trabecular meshwork, then that's a reason for pressure. But sometimes what you'll usually find with IOL related pressures is UGH. So uveitis, glaucoma, hyphema. We'll talk about that in another in a bit more detail. But essentially, you've got an inappropriate lens within the sulcus rubbing up against that iris and causing a lot of inflammation, which kind of in turn causes an increase in pressure. And unless you take that lens out, that can be a chronic problem. And then finally, if you have left any lens fragments, again, this can cause quite a good going bit of inflammation, and essentially just an example of phaco-related pressures and uveitis, which is what I've discussed the sort of the sort of lens-related glaucomas in the past. You can go back and watch that session as well. But lens fragments, again, you've got sort of two approaches. If it's very, very small with lots of steroids, these lens fragments, especially soft lens matter, can slowly melt away. But if you have nucleus, that's really difficult for it to melt. So sometimes you just have to go back in the eye and remove it. So be careful with lens fragments. If you're having somebody coming in after phacosurgery and you're not really finding any cause for their inflammation, and it's just really quite bad, consider doing a gonio, because sometimes these lens fragments can be quite small, and so you don't see them on a non-fast view. You actually need a gonio lens to actually look into the angle and see the soft lens matter sort of sitting there. But with lots of steroids, you can sometimes melt away soft lens matter. I had a patient coming in with a bit of soft lens matter, spoke to VR to consider them for kind of an AC washout because they're the only ones who operate out of hours. Um, but when I gave the patient hourly steroids, by the time they actually got to the VR theater, it had already sort of melted away anyway, so they didn't need to do the AC washout. So you can sometimes melt away with just good amounts of steroids, but um, uh, sometimes they actually just need a washout to get rid of it because the fragment's too big. So with vitreoretinal surgery, there are also complications that can happen, which cause an increase in pressure. Um, and there are different sort of things that you can think about, and it depends on the kind of surgery that the patient has had, the kind of tamponade that the patient has had. So if you start off with, for example, somebody who's come in with retinal detachment, no PVD, young patient who's maybe had a cryobuckle, for example. The buckle can sometimes cause some temporary sort of ciliary body swelling, which can actually cause angle closure. That tends to settle down. So with just temporary measures to control the pressure, you usually just wait for the pressure to settle down, and then once that ciliary body is no longer swollen, things tend to settle. But there are also other problems that are buckle related, and we'll talk about those in future sessions when it comes to actually talking specifically about VR. And then when it comes to the sort of tamponade that's being used, there are also different reasons for why the pressure can be high. So if you've used gas as a tamponade, depending on the type of gas that you've used, they have different levels of expansion post-operatively. So some of them will kind of reach their maximum expansion within about 24 to 48 hours, some of them with a bit longer. So sometimes if they're coming in that sort of period with a very high pressure, it might be because they've essentially been overfilled with gas. Now, that is quite rare. And again, it's usually quite treatable. So you're either going to kind of temporarily manage the pressure, waiting for that gas to start to dissolve, start to be absorbed, which will happen, and that will slowly settle down. Very, very rarely is a patient needing to go back to theatre to have the gas removed, but that may possibly need to happen if it's necessary. But then if you've used oil as a tamponade, oil itself can come into the anterior chamber, it can block the trabecular meshwork. And again, removal of oil can help to treat the IOP, but that tends to need to happen, you know, within the first 6 months. After 6 months, there's not really a lot of benefit to it. But generally, again, you can usually just manage that conservatively without having to go back into the eye. But then vitrectomies themselves can actually also just cause high IOPs. And essentially what's happening is a Gerst cell glaucoma. So you've got photoreceptor outer segments just flushing around into the anterior chamber, blocking the trabecular meshwork. And that tends to happen as a result of retinal detachment surgery, for example. And again, that does tend to settle down, but these pressures can be chronic, and then the patient can then develop glaucoma. So, someone who's not had any pressure problems in the past and has come in for an entirely unrelated issue, either with, for example, cataracts or vitreoretinal surgery, can then sometimes end up with a chronic secondary glaucoma as a result. So it's important to just sort of recognize these different mechanisms. So that brings us to the end of this session. The point of it is just to sort of highlight the different types of pressures that can happen secondary to other interventions. So we can ourselves, as ophthalmologists, unfortunately sometimes induce a high pressure because of treatment, and that's a known risk for what we offer. But those high pressures are not always just temporary. And they can sometimes progress into a chronic glaucoma. And understanding what has caused the pressure is really quite key to management, because that will make a difference to whether or not you're trying to get the patient back into theatre, whether or not you just want to try and manage the pressure temporarily, if there's anything else that the patient needs. Is there inflammation that needs settling? Is it aqueous misdirection? Does the patient have an overfill of, for example, visco that needs to have an AC washout? Trying to figure out what the mechanism is really important, because it does change the first, second, and third steps that you're going to take to try and manage the patient. And the swift management can really make a difference to whether or not the patients develop chronic glaucoma and how much damage actually happens at the nerve. So, thank you for joining. Please do remember to fill out the feedback. And again, we'll see you at the next one.